Dr. Butts, good to see you as well, sir.
Thank you.
Welcome, everyone. My name is Rudy Coombs, and I have the pleasure to being your moderator for tonight's virtual event, Myth or Reality. This is being brought to you by 100 Black Men Health and Wellness Committee under the co-chairs of Dr. Gary Butts and Dr. Michael Lindsay. And I would like to mention Lewis Baldwin, who recently stepped down as co-chair to take care of some personal issues. This event is also in collaboration with Mount Sinai, who's partnered with the one.
Rudy, you just went to mute. Rudy? Rudy, you just went to mute.
I heard you. I don't know why that happened, but anyway.
Now you're back. Okay.
All right. Okay. I was saying this event is also in collaboration with Mount Sinai. Did y'all hear that?
Mm-hmm.
Okay. And it was started under past President Michael Garner and continued on by our newly elected president and leader, Aldrin Ennis. Aldrin, are you on the line?
I am.
Okay, very good. Very good. Okay. With this, with that said, all of these events could not be possible without the approval of 100 Black Men members, board of directors, officers, and our president, Aldrin Ennis. But also, nothing gets done in this organization without our executive director, Courtney Bennett, and his assistant director, Dina Gardner. Before we start, I would like to hear from our president, Aldrin Ennis, and possibly our co-chairs, Dr. Gary Butts and Dr. Michael Lindsay, if they want to speak also. Aldrin?
I am here. Thank you, Rudy, for the introduction. First off, would like to thank the Health and Wellness Committee for the outstanding job that they've been doing. You know, as Black folks in America, we need to be very diligent about our health. So, you know, it's without question that, you know, we have some of the best and brightest on this committee. So first off, just definitely want to thank you guys. And I definitely look forward to the conversation that we're going to have. So thank you very much, Rudy.
Okay. Dr. Butts, Dr. Lindsay?
I'll just add real briefly my thanks to all of us and again, the panelists for making themselves available to bring us up to speed on where we are during these tough moments in our nation's history and across the world. And so hopefully we'll be more informed and smarter and even closer together as we address what's to come. And I want to thank the 100 for allowing this to happen. This is one of several fireside chats we intend to host, and so that we are better together, strong together, and perhaps even a little smarter together. So thank you all.
Okay, with that said, I also want to mention Dr. Reggie Miller, who also helped partner the 100 Black Men with Mount Sinai. Without him, this probably would not have been possible. But Dr. Miller, thank you also. And now I want to introduce our eloquent panelists. Their bio is extremely long, but I had to cut it just so we could get through and make sure that we could have some questions and answers. So without further ado, Dr. Lynne Richardson is Professor of Emergency Medicine and of Population Health Science and Policy at the Icahn School of Medicine at Mount Sinai. System Vice Chair of Emergency Medicine for the Mount Sinai Health System and co-director of the Institute for Health Equity Research, the newest of Mount Sinai's prestigious research institutes. She's a native of Harlem. Dr. Richardson is a nationally recognized expert in health services research who focuses on access to care and healthcare disparities. Next, Dr. Torian Easterling. Dr. Easterling serves as the first Deputy Commissioner and Chief Equity Officer of the New York City Department of Health and Mental Hygiene. Dr. Easterling has spent more than 5 years in a senior leadership role at the Health Department prior to serving as first Deputy Commissioner and Chief Equity Officer. Dr. Easterling served as Deputy Commissioner of the Center for Health Equity and Community Wellness at New York City Department of Health and Mental Hygiene, where he oversaw pragmatic work focused on reducing overall premature mortality and closing the racial gap on the top leading causes of preventable death. And moving on, Dr. Tanya Rogo, excuse me. Dr. Tango Rogo is Pediatric Infectious Disease Specialist at Bronx Care Health System, formerly Bronx Lebanon Hospital Center, where she has wrote the COVID-19 treatment protocol for the pediatric department. Dr. Rogo serves as the secretary of the Manhattan Central Medical Society, which is a local chapter of the National Medical Association, and also was recently appointed to the National Committee for Inclusion, Diversity, Access, and Equity at the Pediatric Infectious Disease Society. These are our panelists, and now I'm going to let each one of them, starting off with you, Dr. Richardson, just speak about COVID-19, the myths, realities of it, and then the other doctors can follow behind you.
Okay, thank you so much, Rudy, and I'm really pleased to be here talking to 100 Black men. Is somebody going to keep time for me? Or should I set my phone to give me a warning?
One of y'all have at least 10 minutes.
Okay, well, all right. You say that like it's a long time, Rudy, but at this point, I could probably talk about COVID-19 for 10 hours, never mind 10 minutes. But I've been asked to talk about a few specific things. So first, I don't think I need to set the stage, and I'm going to leave whatever numbers come out in the presentation to Dr. Easterling. But this is an unprecedented pandemic, and obviously we are still experiencing it. I've been an emergency physician for more than 30 years. I've worked at hospitals in a number of states. I currently work at Mount Sinai Hospital, the big one on the east side. Now I know you probably feel like every other hospital is named Mount Sinai, but I work at the Mount Sinai Hospital on the Upper East Side. And I also work at Elmhurst Hospital Center in Queens, which is run by Health and Hospitals Corporation. And I work in the emergency departments of those two places. And what I experienced as a provider on the front lines, taking care of patients with COVID in the months of March, April, and May of this year were obviously unprecedented. We saw actually the first case of COVID that was diagnosed in New York City at Mount Sinai Hospital. It was diagnosed on March 1st. And by March 31st, we were seeing 1,600 new hospitalizations per day in New York City. That's how fast the pandemic exploded here in New York. And so obviously all of our healthcare institutions were overwhelmed. The emergency department is the front door, and we certainly were under siege in a way we never had been before. The strategy and the excellent public health messaging that went out from our New York City Department of Health and Mental Hygiene was to try to keep all but the sickest people from coming to the emergency department. And so that was effective and had some actually unintended consequences that I'll talk about a little later. And so we were easily seeing 100, 150 patients a day in our emergency department, people with symptoms of COVID. Most of them got discharged home. Many of them got hospitalized. Some of them got intubated and some of them died in our emergency department before we could even get them upstairs. So it was an unprecedented toll on our healthcare system, certainly on our emergency department resources, on our emergency department providers, because unlike many New Yorkers, everybody who works in the emergency department was going to work every day throughout the pandemic. And that's not just the physicians and nurses who have been, and rightly so, applauded for their heroic efforts, but it's our techs and our registrars and our transporters and our housekeepers and the entire team that keeps the department and the hospital running. And they really all deserve our appreciation for the courage that they showed. Despite their concern for their families, their worries about contracting COVID and taking it home, they came to work every day. And so the emergency departments did see a marked decrease in volume. And this was not just here, but across the country. And there was an early report from the CDC that almost 50% decrease in volume overall from emergency visits. So the messaging to stay home unless you're very sick did work. But the question becomes then, what happened to all of the other things that we usually see in the emergency department? And I'm going to come back to that in a couple of minutes. So what did we do? So the emergency departments expanded. We took over a territory that previously had been used as a walk-in clinic, because again, sort of the kind of people who were walking into walk-in clinics were staying home. They were not walking in. The hospital surged and created across the city thousands of new beds. Here at Mount Sinai, we built beds in our hospital lobby. We had beds up in what had been the cafeteria. We erected a hospital tent in Central Park. Every one of our emergency departments expanded into a tent outside the ED door to allow us to see the volume of patients that were coming in. And surge is something that hospitals have planned for decades, but never before have our plans been put to the test the way they were in March, April, and May. I want to address the theme of this, which is myths and realities. So I've heard a lot of myths and speculation and fantasy about what went on in emergency departments and hospitals during that pandemic peak. I've heard people say that care was rationed, that ventilators were rationed. I think there are all kinds of misinformation, sensationalization in the media that have shaped a lot of very concerning pictures of what went on. I can certainly say that did not happen where I worked or any place that anyone that I personally know has worked. We certainly started talking about contingency plans, but we in fact did not run out of ventilators. We did some extremely innovative things to convert some other pieces of equipment into ventilators. We devised some methods that would allow ventilators, excuse me, to ventilate more than one patient at a time. But we never got to the point where I, as a physician, had to decide who would get care or whose life would be saved, and who would be allowed to die. We did not get to that point, certainly not anywhere in the Mount Sinai healthcare system. And I think this has driven a lot of speculation about how should those decisions be made. And certainly there were a lot of conversations about how we should make those decisions if it got to that point, but it certainly did not get to that point. So that's one myth I would like to dispel. The other thing, I guess, is I want to talk about is what happened to all of the rest of the business that I usually see in my emergency department. there was a point during the pandemic peak when 90% of what we were seeing in our emergency department was COVID. And so where was everything else? Where were the strokes? Where were the heart attacks? Where were the ruptured appendices? Where were the GI bleeds? Where were all of the things that we usually see in the emergency department? The answer is many of them stayed home because they were afraid to come to the hospital. And so the very important and very necessary public health messaging that told people to stay home, unfortunately, sometimes led to people who should have sought care in the emergency department from seeking the care they needed. And we are now starting to see, as more and more data comes out, that deaths from all causes rose during that period as people decided to forego emergency care and stayed home. And some of them died. Some of them had events, and now we see them coming in with complications. They have new heart failure because they had an untreated myocardial infarction. They're now in kidney failure because their blood pressure was uncontrolled for several months because they were afraid to go to their doctor, and they didn't come in when they had symptoms. And so this issue of foregone care is really an important and somewhat overlooked one. It disproportionately affected people of color because our access to care in our communities was the most disrupted by COVID. Like many other places, our urgent care went virtual so that you could have a tele-encounter if you were not very sick. Not everybody has access to that technology, and not everybody feels comfortable using that technology. And so some of the disruption of primary care and in fact of emergency care that happened during COVID was mitigated for some populations by telehealth, but not for all of us. And I think one of the important lessons that we need to learn, and some of the interventions we need to start working on, is what do we do now so that going forward we don't see this kind of disproportionate impact when we have this kind of disruption in care. Others on the panel, I'm sure, are going to talk about the health consequences of COVID and the disparities amongst Blacks and Latinx people, and among certain socioeconomic group and among certain residential communities. But beyond the health impact, there's been a huge financial impact on our communities, and there have been indirect health impacts on every other thing that affects our people: hypertension, diabetes, heart disease, asthma, COPD, kidney disease. All of these now have been adversely affected by the lack of access to care that occurred because of the disruptions in the health system during the pandemic. So as a result of the pandemic, Mount Sinai, as was mentioned in my intro, recently established an Institute for Health Equity Research. And the driving force really was the racial and ethnic disparities that we were seeing during the COVID pandemic. And so now Mount Sinai, which has used this model of a transdisciplinary research institute to address some of the most pressing problems in basic science, is now using this model to address health equity science. And one of the first things that we did at the new institute is that we collaborated with over 100 community-based organizations to launch a survey. It's called Speak Up COVID-19. And we deployed this survey in 11 languages to try to find out what was really going on in communities around the city as a result of COVID. And we have about 2,000 responses so far. We are still collecting data. And the most striking thing that we have learned thus far is the impact that this has had on people's mental and emotional well-being. 75% of our respondents are expressing symptoms of anxiety. 50% are scoring for significant symptoms of depression. 40% are reporting symptoms of PTSD, post-traumatic stress disorder, related to the COVID pandemic. And so we have to deal not just with the SARS-CoV-2 infection, but also the financial distress that has been caused by this pandemic, and now the impact that this is really having on the mental and emotional well-being of our communities. To have COVID, and then layered on top of that, the police murder of George Floyd, and the sort of now outpouring of focus on racism and social justice. It's really community trauma, and the grief that we have, especially in Black communities, where all of us know personally someone who has died from COVID, is enormous. And so these are the challenges that really are facing us now as healthcare providers. It's facing us as researchers in the Health Equity Research Institute to really understand and start to work on the strategies to address all of these very important health issues created by the pandemic. So I'll stop there, and I'll be happy to take questions. Or I don't know if you want to save questions for the end.
We'll hold the questions till all the panelists speak. Thank you so much, Dr. Richardson. Dr. Easterling, you're up.
Sure. Well, I'll just first by say thank you to 100 Black Men, to Dr. Butts, Dr. Miller, and so many others for making sure that I had a chance to be a part of this discussion. And I think it's an important discussion that we have to continue to have as we continue to face this unprecedented moment, as Dr. Richardson just mentioned. And there are multiple moments that we're trying to address. So I'll talk a bit about the work that the health department has been leading and co-leading, I would say, in certain areas, what our priorities are, where we are right now. I think, sort of painting a broad brush without having to go into the data too much. The narrative and the stories around the disproportionate impact on COVID-19 has been covered and could not be overstated enough. But as we look ahead, I think the priorities for us as an agency, making sure that we could prevent and rapidly address a resurgence in COVID-19 infections and in really addressing this pandemic continues to be our #1 priority as an agency. Part of that priority has to be supported by 2 additional priorities, and that's going to be, and I'm sure Dr. Rogo will talk more about it, but our planning and preparation for citywide immunization. And that's both thinking about our flu vaccine strategy, as well as when COVID vaccine is available, how we're thinking about an equitable allocation for certain workforce as well as certain communities. And Dr. Richardson hit the nail on the head and sort of thinking about again, the moments that we are addressing, not just being COVID, but certainly meeting this moment of how we are continuing to combat structural racism, to disrupt it, to uproot it, and really to advance a health equity agenda. And as a public health agency, this was something that we really needed to position ourselves about how we're talking about structural racism, how we're naming racism as a public health issue, and what are the interventions that were going to be important as an agency that we were going to employ. As we continue to look at sort of this first priority of really pushing back, I'm going to say, first and foremost, our data is going to be really important. We need to be able to be transparent. We need to be clear so folks understand where we are right now and where we're going to be in the next couple of days and the next couple of weeks. Planning our life out isn't the same way that we used to do it, but we know that people, sort of hinge on this type of information. We are continuing to look at the data closely by neighborhood, by race and ethnicity, by age. We continue to look at our public health indicators closely until that includes percent positivity. Right now, we're at 1.46% positivity across citywide. If we remember, over the summer, we were as low as, we were less than 1%. And so, you know, if I could say anything, I do think, you know, that we need to be vigilant, right? COVID has not gone away. The other indicators would we continue to look at hospitalizations and cases overall. I can say that we continue to be under all of the thresholds for our public health indicators. One that we will certainly surpass, if not by the end of this week, but certainly by the next week, are the number of new cases. If folks have been paying attention to these indicators, new cases, we set the threshold at 550 new cases, and we're at 516. This doesn't mean that we're in a resurgence, but what this means again is that we really have to impress upon people that COVID has not left, that we really have to double down on our messaging and our core 4 recommendations of wearing face masks, social distance, making sure that you stay home if you're sick, and washing your hands, and following those hand hygiene practices. We're only talking about one indicator, and we're looking at all of them. But I think I cannot, you know, just emphasize enough how serious we think that this is. You know, if we could sort of pinpoint an analogous moment right now, I would say that we're at February. You know, as Dr. Richardson just talked about, the first case, March 1st at Mount Sinai. No, we're not there yet, but we want to make sure that we can continue to push back on any type of resurgence. We are seeing increasing cases. We're, you know, as the governor has announced, the New York State COVID zones, one area in Brooklyn, 2 parts of Queens, Eastern Queens, as well as in Far Rockaway. What we can say is that we continue to work with the state to think about the interventions that we think will be effective at a local level. Since the summer, we've been really thinking intentionally about hyper-local strategies. I think that this is a way that we're meeting the moment to really push back on a resurgence, but also thinking about equitable practices. The data already told us where we saw disproportionate impacts, and so we were already monitoring certain neighborhoods. We were looking at neighborhoods where we saw high rates of poverty, where we saw high rates of underlying conditions such as hypertension and diabetes. And we were looking at sort of long-standing inequities. And so parts of Brooklyn, parts of the Bronx, parts of Queens, where we certainly saw this disproportionate impact. And we said, how can we marshal all of our resources, bear the resource that we have at our disposal in the neighborhoods where we saw these disproportionate impact. And so using both data as well as our contact tracing efforts and our community partner relationships, we had implemented some hyperlocal strategies of doubling down on our messaging, bringing mobile testing to specific areas, whether they were mobile testing or standing up testing operations. But also what was really, really important and what anchored all of that work truly was really having shared leadership practices and ensuring that we had partners who were going to work with us to ensure that they were the trusted messengers, they were the ambassadors in those communities. And so over the summer, we were in Sunset Park, we were in Soundview, we were also in Tremont. And really what we saw was that, you know, really to lead this, we really needed to have our partners being out front, talking about how important it is to get tested, talking about how important it was to, if you were positive, how to isolate, and if you're a contact, to quarantine. And those messages were supremely were valuable. We then worked with providers in those same communities to also make sure that we were supporting our federally qualified health centers and even our small practices to ensure that their testing capacity could be increased. And so those local strategies, and as we've been looking at our data and seeing who has been testing positive in those neighborhoods, we can certainly see how the cases did go up, but they certainly also went down. And I think that was a true effort of collaboration and making sure that we were bringing our resources there and making sure that we were getting the message out to individuals that if you did find out you were positive, what those next steps were. We didn't see sort of the same, sort of the same trajectory in some of the cluster areas. And I think that's why we are now moving to more aggressive actions and having some enforcement and restriction on some of the activities, and certainly not restricting movement. But what we're saying is that COVID is still out there. The concentration of cases that we're seeing in these cluster areas, just testing is we're not going to be able to test our way out of it. And we really need to restrict the ways in which people are coming together, coming in close contact, and contributing to community transmission. And I think that's the message. I think we want to continue to say that we're still at a point where we think that our provider capacity, our testing capacity, our data and our testing and our tracing efforts have really been valuable in this effort, and we've been ensuring that we're hiring from communities and making sure that they're being a part of this effort, this citywide effort. And it's really been valuable to have both community-based organizations that we funded to support with outreach, as well as individuals that we've hired from the community to be a part of the contact tracing team, who have been indispensable in contacting, engaging individuals, and making sure that we're getting folks connected to those services. And so, if folks have not had a chance to see it, I will add the link for the Cluster Action Initiative, where you can see the 3 zones, the red, orange, and yellow zone. In those areas, we continue to saturate the neighborhoods with outreach around messaging, face mask distribution, but we also continue to look at other neighborhoods across the city as well. As I said, we're monitoring citywide data, and we continue to look at neighborhoods that could certainly move in the same direction as these cluster areas, but also we're also seeing some improvements as we have been rolling out this Cluster Action Initiative in concert with the state. So I think what we're saying is that, if we continue to be vigilant around this message, I think that we could certainly not see anywhere near the number of cases that we experienced in March or in April. And I think that's going to be really important, that this has to be a collective approach. And I'll just one more thing, because I do think it's going to be super important, that we really have to message how important it is to get our flu shot this year. We've been saying that this may be one of the most important ones, but it should not be the only one that you get. And so even continue to get your flu shot after this year, because I think we will continue to have discussions within our community and acknowledge the distrust and certainly the skepticism around getting a vaccine. And this has to be a part of our community partnership engagement and thinking about how we're having conversations and really sort of unpacking the distrust so that we can move past, into a recovery period past this pandemic. And so I'll stop there, and I look forward to the questions.
Thank you very much, Dr. Easterling. Dr. Rogo, you're up.
Hey, hello, everyone. Thank you for having me. So I was asked to speak about the COVID numbers, how COVID is spread, prevented, go through the treatments, and also the vaccines. So starting with the COVID numbers, Dr. Richardson and Dr. Easterling touched on this briefly. But right now, there are 38 million cases worldwide, and the US is #1 in the world, followed closely actually by India. We right now have 7.8 million cases, and India has 7.2 million. And there have been 1 million deaths worldwide from COVID since the pandemic began. And quarter of those, 216,000, have happened in the US. So to just give you a context for what those numbers mean, probably the last outbreak you may remember is Ebola that happened back in 2014, ran 2 years to 2016 in West Africa and a couple of cases made it to the US and to Europe. That one killed 11,000 people, right? And that ran over 2 years. And Ebola is much more deadly than coronavirus because Ebola actually has a 50% mortality rate if you catch Ebola. And then to compare it also to the Spanish flu pandemic. So the Spanish flu pandemic has been the deadliest pandemic till now. Happened from 1918 to 1920, so over 2 years. And that one killed 675,000 Americans over 2 years, right? So we're only 6 months into the pandemic in this country and we're already over 200,000 deaths. So if we continue at the current rate, and if, as predicted, as some people predict, this pandemic ends up running around 2 years, we're definitely going to surpass the 675,000 people who died, Americans who died with the Spanish flu pandemic 100 years ago at the current rate. So moving on to how it spreads, because that goes into how we prevent it. So COVID is a coronavirus. It's a respiratory virus, and it's spread person to person. Primarily through droplets. So droplet means that when you're talking or you cough or you sneeze, you produce small particles of saliva that contain virus in it, and it can go up to 6 feet, which is why we have the recommendation for social distancing in the stores when they have the circles on the floor, the 6 feet apart, because that should hopefully put you outside the range of someone who's producing droplets. There's questions as to whether or not it is airborne. Lab studies show that it is airborne. So airborne means that if I talk and then I leave the space, that the particles I produce are still hanging in the air after I leave, right? And the problem with diseases that are airborne is that they require higher levels of protection than droplets do. You need a different level mask. And then it also can live on surfaces. So different studies have shown that it can live on surfaces for up to 3 days, which is why the recommendation is that you should actively wash your hands and also disinfect the surfaces around you. So in terms of prevention, hand washing is one of the main ones, and then also mask wearing. So I brought some of my masks for show and tell. So in terms of face coverings, the lowest level type face covering is a cloth mask, right? And whatever mask that you wear, even if it's a scarf or bandana, should always cover your nose and your mouth. The next level up is a surgical mask, which you should definitely wear if you work in healthcare. And okay to wear if you're taking care of a patient that doesn't have COVID symptoms or doesn't have actual coronavirus. And then next up is the N95 mask. So the type I have, this is the duckbill kind. And so the N95 mask is the type that you would use to prevent airborne transmission. So airborne diseases include measles and TB. So these are the next level up. And if you work in healthcare, it's recommended now that if you see patients, you at very least, if they don't have COVID, you wear a surgical mask and you have an eye shield, right? Or a face shield to cover your eyes. So those are the different things that we have in terms of prevention. So mask wearing, hand washing, and also avoiding crowded areas, right? So social distancing, so you're not within the reach of people's droplets. If you're going to be in a group, it's encouraged to be outdoors so that you have air circulating around you. If you are exposed to someone with COVID, the incubation period is up to 14 days. So it's recommended therefore that you quarantine for 14 days until you know for sure that you're not infected. If you are unfortunate in actually getting COVID, then you're supposed to isolate for at least 10 days from the onset of symptoms and at least 24 hours from when your symptoms go away. Now, there are studies showing that people can test positive for COVID continually up to 3 months out from when they first get sick. But it's thought that for most people, after 14 days, the virus that they detect is not the type that can replicate and can cause disease. That's what's thought so far. And then the other thing also that's been coming up is about reinfection, right? So that you've probably seen the headlines talking about people who've had COVID and then a few months later get it again. And that it's still unclear whether or not you can get reinfected. We do know that it seems like the antibodies do wane. So when they check antibodies of people who've had it, and then they check a few months later, it looks like the antibodies levels do go down. So we still don't know if the antibodies that you generate from getting COVID are actually protective against you getting it again. So moving on to the treatments. So the one that initially made a lot of headlines was hydroxychloroquine. So hydroxychloroquine is a drug that's used to treat rheumatologic diseases. And chloroquine also was being talked about. So this is a malarial drug that we don't really use anymore because most places in the world have malaria that's resistant to chloroquine. And when COVID-19 first started in China, they, as part of their treatment protocols, were using hydroxychloroquine and chloroquine, which is why when it came to the US, people started to use it. And then the FDA, unfortunately, bowed to political pressure and issued an emergency use authorization for hydroxychloroquine, even though there were questions about its efficacy. But since then, studies have shown that it really doesn't seem to be of benefit, and actually, for some patients, actually causes adverse outcomes. So the current recommendation is against hydroxychloroquine for treatment of COVID and also for prevention of COVID. Remdesivir is actually the drug right now that's looking promising. So this is an antiviral drug that came into development for actually treatment of Ebola, but it didn't really work against Ebola, but it seems that it works against COVID-19. And there was a pivotal study that came out over the summer where they had patients who had pneumonia due to COVID-19. And for the people, the arm that received remdesivir versus the placebo arm, remdesivir seems to shorten the amount of time that people were sick for, right? So they were sick for 10 days versus 15 days in terms of clinical recovery. So remdesivir right now is available in most hospitals, with the current indication being to give it to someone who is hospitalized and requires oxygen at the very minimum. And then the next option is convalescent plasma. So convalescent plasma is essentially blood that's been collected from people that have survived COVID-19 because their blood is full of antibodies. And it's currently in the trial phase. And right now, we don't know if it's actually an effective treatment because we're still waiting for the outcomes of the clinical trials. And then there's also the monoclonal antibodies. So I think the one that made headlines recently is Regeneron, which is what President Trump received. So we really don't know much about the monoclonal antibodies because they're also in the trial phase, right? So it would seem that the president must have been enrolled in a study for him to have gotten Regeneron because it's not available.
I have to stop you.
Yes.
He was not enrolled in any clinical trial, and
Okay.
NIH was not involved in treating the president with that drug.
Okay, so therefore
you can figure it out yourself how he got it.
Well, he's apparently I think a shareholder of the company, so that's maybe how he got it. But moving on, there's also the use of steroids that also has come into play. So it seems that for people that have moderate to severe disease, particularly if they're on a ventilator, the addition of steroids is actually helpful. So one of the things that we've added to our arsenal. And one of the things that has been challenging for us clinicians in terms of taking care of COVID patients is all the new things that keep coming up with COVID. And so we learned in the course of treating patients is that they tend to develop thrombotic events like strokes, pulmonary embolisms, clots in their legs. And so one of the things we do for all patients who get admitted to the hospital with COVID is that they now get put on anticoagulation or antithrombotic therapy to prevent those types of complications. Another thing that came up over I would want to say like May, was something called multi-inflammatory syndrome in children, which was, it seems to be a post-infectious syndrome that occurs in children who've had COVID-19 about a month before. Most of the time, they don't even realize they have it because most children actually only have mild disease. and then a month later come in with chest pain, sometimes diarrhea, and have multi-organ issues. So they can have heart failure, kidney failure, neurologic issues, and the treatment for which is to give them anti-inflammatory therapy, so receiving immune globulin and or steroids. And what's actually interesting about MISC is that we've only seen it in North America and Europe and not in Asia, particularly not in China. And so there seems to be a difference in the type of virus, because we know that the virus that we have here in New York originally came from Europe, that for some reason, the type of virus that we have seems to be causing this post-infectious syndrome in some people. And now what we're also seeing actually is multi-inflammatory syndrome in adults, so MISA. I actually just had my first patient with this this week. It was actually 19, so she's technically an adult. So now the question is coming that maybe some of the complications that we're seeing in adults over the summer initially maybe was this entity, MISA. So that's treatment. So next I'm gonna go into talking about the vaccine. So when I just looked this up today, so the World Health Organization currently says that there's 180 COVID-19 vaccines currently in development, which I just think is crazy. Before I go into the type of vaccines that are being developed, I just want to briefly explain the different phases of clinical trials that lead to the development of a drug or a vaccine. So there's 4 phases. With phase 1 is where they look for the best dose of the particular medication or vaccine to work. That's phase 1. And that's usually very small. Phase 2 is now when they look to see if it's safe and also look at efficacy. So that tends to be larger than phase 1. And then phase 3 is where they assess for side effects. And phase 3 trials are usually randomized trial, and at least one arm usually is the placebo arm, where to compare them to the people who receive the actual treatment. And then after something is licensed by the FDA now to go into the public, there's then the phase 4 phase where they continue monitoring this particular new medication or vaccine to look for any short-term and long-term side effects and safety, right? Because sometimes things come up after licensing and they have to pull something off the market. So the last vaccine this happened to was the rotavirus vaccine, which we give to babies. The first one that came out ended up getting pulled from the market because it seemed to have a higher association with intussusception. And then also, in general for vaccines, any patient who develops any kind of event after a vaccine is supposed to be reported to something called the Vaccine Adverse Event Reporting System, which is the surveillance for any type of new things that may come up, any issues that may come up with a vaccine, right? So in terms of vaccines, there's continual surveillance of things even when they come onto market. So moving on to coronavirus vaccine itself, there has never been a coronavirus vaccine developed. Coronaviruses are respiratory viruses, and there are many of them. And the problem with developing vaccines for something for which you have many strains is that the strains mutate and change, so it makes it difficult to make something that you can be immune to, right? That's part of the challenge that we have with the flu vaccine, is that there are so many strains that change every year, that what they try and do is that they try and predict which strains are going to be circulating in that particular year. So there's never been a coronavirus vaccine ever developed. And the government has something called Operation Warp Speed, where they aim to produce and deliver 300 million doses of the vaccine, with initial doses to be available by January 2021. That's literally less than 3 months away. It is impossible. And I wish the messaging would change a little bit to change people's expectations, because people have put their hat on the vaccine to be the cure to the pandemic. But we know historically, anytime that you roll out a vaccine to eradicate a disease, it takes years. It takes years. Polio still hasn't been eradicated. I think we're down to like the last 2 countries, Pakistan and Nigeria, right? Measles took 30 years for us to eradicate. Even then, we just had a measles outbreak in New York that ended a year, almost 2 years ago now. So it's going to take a really long time once you roll out a vaccine to actually get rid of the virus that you're trying to get rid of. And in terms of using a vaccine in the context of an outbreak or a pandemic, so they actually did this with Ebola this last time. So you may or may not be aware that more recently there was another Ebola outbreak that happened in the Democratic Republic of Congo, started in 2018, and it's almost, I would say probably towards the end now. And so what they did was they had a vaccine in development, not licensed for commercial release, that they used in the context of ring vaccinations. So what they did was for people who, if you are contact of a person who was diagnosed with Ebola, they would vaccinate you, right? So if I had Ebola and I have to say I have 5 people living in my house, they would come and they'd vaccinate the people around me, right? It's called ring vaccination. And they found that to be an effective method of controlling the spread of Ebola. And so the only people who actually got the Ebola vaccine were direct contacts of Ebola patients, and also frontline workers in the districts that had Ebola, and also the neighboring countries, so Rwanda and Uganda. All the doctors and nurses who work right along the border with the Democratic Republic of Congo also got vaccinated. So they didn't try to distribute it to everyone, right? It was just for the people that were at risk. So in terms of the coronavirus vaccine itself, there's currently 5 different types of vaccine that are being worked on in terms of the clinical trials. 4 of them have been successful in the past in producing a vaccine. The 5th one, which is the RNA vaccine, which is the one that you probably hear about the most, because that's the one that the NIH is working with Moderna, and Pfizer also is working on an RNA vaccine. There has never been an RNA vaccine that has ever been licensed, ever, right? So that's so working with a method of developing a vaccine that previously has not been licensed for human use. And so that's the RNA vaccine. The other 4, we have successfully developed vaccines before. So one way is a virus vector. So virus vector means that you use another virus as a vehicle to introduce the coronavirus into your body. So this was used for the vaccinia vaccines. The vaccinia was the very first smallpox vaccine that was used. So AstraZeneca, currently that's the one that they're working on. And then actually, you may have heard that Russia has recently licensed a vaccine, and there's also one that in China that's been released for limited use. So both of those are virus vector vaccines, and they're using the adenovirus as the vector. And I can't say anything about the efficacy or the safety of those vaccines because we've not seen any results of any trials. The next one is an activated vaccine. So inactivated means that they've essentially killed virus particles so that they can't replicate. So inactivated vaccines, examples are the influenza vaccine, the one that you inject, and also the polio vaccine that we use in this country. Those are inactivated vaccines. So that one also currently the Chinese have given emergency approval for, but again, we have not seen any data from it, so I can't attest to its efficacy or safety. And then the next group are the live virus vaccines. So we use live virus vaccines in MMR, which is measles, mumps, and rubella, the yellow fever vaccine, varicella or chickenpox vaccines are all live virus vaccines. And so what they do is that they take the actual virus and weaken it so that it can't cause disease, but it can replicate a little bit so that it can create an immune response when you see it in your body. So that vaccine currently is being developed in India. And then the last one is a protein sub. Sorry?
Got a couple more minutes, Dr. Rogo. I want to start the Q&A, okay?
Yes. So I'm right. Thank you. That's right. I'm right at the end. So the last one is a protein subunit. An example of that is a hepatitis B vaccine. So this is when they take just the protein part of the virion and to trigger an immune response. And that particular vaccine is the one that's being developed in Australia and is in phase 3 trial right now. So that's the one that the Australians are hoping to use. And then in the news this week, you've probably heard Johnson & Johnson paused their clinical trials for their vaccine because a study participant became sick with an experimental illness. And last month, AstraZeneca actually put all of their vaccine trials on hold after a participant in Britain got a neurological illness. They've resumed their trials in the UK, but it's still on hold in the United States. So that tells me at the very least that the data safety and monitoring board. So anytime you have a trial, there's always an independent board that's supposed to monitor a trial and stop a trial if there's any concerns about the safety. Or sometimes what they do is that if the treatment arm shows a better response, they stop it early because they also want the placebo people to get the same treatment, right? So the fact that trials are being stopped doesn't necessarily mean that the final vaccine is going to be dangerous. It just means that the safety boards are working, right? They're stopping things if things seem to be going wrong. So I think I'm going to end there and let the Q&A part begin.
Okay, everybody, the panelists are totally awesome. Some phenomenal information. We thank all of 3 of you for the information that you just gave to all of us on this virtual event. What we're going to do now, so we can keep it still organized, is that we're going to ask each doctor questions. So you have an opportunity now to put your questions in the chat. Dr. Butts is going to be pulling out questions in the chat. I myself have questions for you already that I've made with the committee that I'm going to ask. And you can ask individual doctors, or you can ask the question for all 3 doctors. That depends on you. Just let us know if the question is for one doctor specifically, or if it's for all 3 doctors. So I'll start it off. My first question is to you, Dr. Rogo. Can you explain the PCR COVID test and its effectiveness? It's supposed to give a 24-hour result.
Yeah, so the PCR looks for actual live virus. And most of the tests that we have right now, it's a nasopharyngeal, meaning that they stick the swab way it feels like it's going up into your brain. And depending on where you get tested, it's just about the turnaround time of the test. So if you're in a place that runs it 2 or 3 times a day, you may get a result sooner than 24 hours.
Okay, thank you so much. I see a question in the chat here. How can individuals advocate for their family members who are hospitalized with COVID given visitation limitations at hospitals? Any doctor can answer that, please.
So right now, most hospitals have rescinded the restriction of visitors, and they are allowing visitors into the hospital. It is much more limited than it was pre-COVID. It's usually 1 at a time for a total of 4 hours a day. But I think this was one of the most difficult things really for both families and for hospital-based providers during the peak, that patients became cut off from their family members once they were hospitalized. It was, I think, absolutely essential to limit the number of people who were going in and out of the hospitals. But we should have had better contingency plans in place to electronically connect patients with their visitors, being, iPads or cell phones or what have you. This is something that hospital staff spent a lot of time doing, calling patient families on the phone and giving them updates so that they would know. But for right now, you actually can visit your loved ones in hospitals. That was not something the hospitals decided, by the way. That was a gubernatorial order that came from the state. So it is it is difficult, but believe me, the hospital staff will do everything possible to try to keep you informed should we have to go back to that no visitor policy. We know how hard it was on families, especially for those who's had, you know, loved ones enter the hospital and then they died, and, you know, they died alone without family around them. It was very hard on everyone.
Okay, that question was from Dr. Miller, and he wants you also, Dr. Rogo and Dr. Easterling, to answer that.
About visitation?
Yes. The question again, how can individuals advocate for their family members who are hospitalized with COVID, given visitation limitations at hospitals?
Mm-hmm. So I think asking for the phone number or giving your phone number to the nurse and the physician taking care of your loved one, so that they can call you with updates. I've done it, and both as a doctor calling family members, but also even as a family member, having someone in the hospital, had them give them my phone number and they would call me every day with an update. So that would be one way to do it.
Okay. Okay, Dr. Easterling?
Yeah, I wouldn't say I have much more to add than what Dr. Richardson and Dr. Rogo has already shared. I think the more that we can learn about, you know, the treatment, learn more about, you know, sort of the management, I think that will give individuals a better understanding of the process and prognosis of where their family members are sort of in their recovery. I certainly think that, you know, the ability to also, if possible, leverage their primary care provider. And I think, you know, to Dr. Richardson's point, you know, I think we're going to have to message better, you know, making sure that individuals who do have primary care providers, and I think it's going to be really important that they continue to remain in touch with their primary care provider so that they are aware of their patients and can also be advocates as well. And I think that because we sort of, you know, we cut off, you know, sort of the ability for primary care providers to know what was happening with their patients, they also were not available to advocate as well. So.
Okay, thank all three of you for that. Dr. Easterling, my question to you is, what vitamins that we can take? They talk about vitamin C, vitamin D, and zinc. What would you recommend to help with strengthening our immune system, if any of those vitamins?
Yeah, I think the first thing to say, just because, you know, I wouldn't say that there's one vitamin as a broad brush that would help everyone. I think one, I would say, you know, checking with your provider. I think that's an important question and an important conversation that one has with their provider. You know, just given, you know, the conditions that folks are dealing with, medications that individuals are on. I certainly think that, you know, messaging around, you know, healthy food intake, exercise, because those were also concerns, you know, certainly during wave one in March and April, the ability to continue to exercise, you know, not to be sedentary, making sure that folks have access to nutritious food. And even though, you know, the city was supporting with food access and really trying to address food insecurity, I think healthy options are going to continue to be key. And I think also overall mental well-being, just, you know, isolation can weigh heavy on us, and as a result of stress can have an impact on our immunity as well. And so I think those are the things that we have to remember, and, you know, just good food intake, exercise, really trying to address stress and anxiety. I think specifically to the vitamins, I think, you know, again, talking with your providers about which is the best one, and also taking into account other medications that you may be taking.
Okay, thank you, Dr. Eastman. This question is for Dr. Rogo. It's from Brian Jones, and he wants to know, what is the percentage level of the disease that is introduced into the body that is considered ineffective?
So we don't know the answer to that because I think it depends a lot on, one, the health of the person who's getting infected, right? So if you're immune compromised in any type of way, if you have comorbidities like asthma, diabetes, or anything else like that, you're going to not be able to fight off the infection as well as someone who's completely healthy. We know there's other risk factors like age, gender also seems to be a risk factor. So, you know, what a small amount of virus to me may mean may mean something different to the person who's sitting next to me, depending on what's going on with their health. And sometimes people don't even know that they have a risk factor unfortunately, until they get sick. And the also thing that we don't know is does it matter how long the person has been sick with the virus by the time you meet them, right? So if someone has had coronavirus for 3 weeks, then we think that the particular virus is not as infective or as virulent as someone who's just infected. So it's actually a question that we don't really know the answers to in terms of what is the level of virus that you need to be exposed to in order to get sick or not get sick.
Well, I think you did good trying to answer it. All right, next question is coming from the committee. Reggie Pittman asked this question: what are your recommendations to treat diseases holistically? Nutrition, exercise, sleep, prayer versus pharmaceutical prescriptions and surgery. This is for all three of you guys.
I can go first. I think staying healthy and then if you get sick, recovering from an illness takes a lot of pieces of things, right? So it's not just the pharmaceuticals, but also how healthy you were to begin with, right? So you're someone who already used to eat a healthy diet. Do you have any comorbidities or anything like that? Do you have any genetic predispositions? But also we all know, I'm sure, that what's going on mentally and spiritually also can help someone in terms of recovering from an illness, right? And I think one of the things that was very difficult with COVID was that people got sick and got admitted and were alone, which makes it, you don't have someone to take care of you, to feed you and look out for you and sing to you and read you stories. So all of those things are, I think, equally important pieces in terms of someone's health.
Okay, thank you. Dr. Easterling?
Yeah, I totally agree with Dr. Rogo. I think, really thinking about our overall well-being, as the question that has been presented, I think those points around exercise, good nutrition, really thinking about reducing stress and anxiety, sleep. I mean, these are things that, we've been, has been preached to us for decades, and I think we need to continue to follow through on them. And I think that's on the prevention side. And I said, I think the point around treatment, I certainly think that we need to find our primary care provider, making sure that we're getting screened for certainly the leading causes of death around, heart disease, diabetes. We know that cancer is the second leading cause of death. This is not going to go away with just vitamins. We need to make sure that we're getting screened, and we need to follow through with our primary care provider to really understand what our next steps are. Management cannot, it's not there's no one answer to this. And I think that's why having your primary care provider walk you through sort of what the next steps are is really, really important here.
Thank you, Dr. Easterling. Dr. Richardson?
I certainly have nothing to add to that. I agree. I think a healthy lifestyle probably is perhaps more important. We know that all of the context in which you live and all of the social determinants are probably more responsible for your general level of health than the health care you receive. But I joined Dr. Easterling in that once once a problem is identified, and even identifying problems that actually do require treatment is also important. And so you certainly should take excellent care of yourself, get enough sleep, nutritious food, and all of those things, exercise, but you also need to get appropriate health care. So it's not one or the other, it's everything in balance. I also just want to add one thing about, there was a testing question earlier. There are lots of tests, just as was mentioned, there are 180 vaccines in development. There's probably over 100 diagnostic tests for COVID that have come out over the last few months. Some are better than others. PCR is the most common. There is now a rapid test that actually gives you a result in 20 minutes. But these are not generally available, and they've been, the companies that make them are startups that haven't been able to produce them in the quantity that the healthcare system needs. So there's a whole range of different tests that are being used, and they are getting better and faster over time. Right now in New York City, most places you go for a test, you will wait usually at least 1 to 2 days for the results. But there are, sometimes it's more like 5 to 7 days in some places, but there are places that reliably will give you an answer within 24 hours. So there's a lot of variation. If you're in a hurry, you kind of need to research it, where to go for which test.
Okay, since you're talking about that, Dr. Richardson, I'm going to ask you a question also.
Okay.
With the COVID-19 and sticking the swab up your nose, right? What's the difference with the antibody testing and the COVID-19 testing? Because a lot of people prefer to do the blood testing instead of having the swab up their nose.
Totally understand. So the COVID-19 test, which the most common approach right now is the swab to the back of your nose. That's how you detect the fact that you've been infected by the virus, because this particular virus likes to congregate itself in the back of your nasopharynx, so the back of your throat. So it can be tested for by swabbing that area. There's lots of active research right now looking at whether or not a swab to the front of your nose or even a saliva test can be just as accurate as the swabbing in the back of the throat. Those have not yet been validated, but they are coming. The antibody test becomes positive after you've had the disease. So the nasal swab is to see if you've been infected. Once you've been infected, your body develops antibodies, and those take some period of time to build up in your blood. And so after you've had the disease, and on average, they start to show up about 2 weeks after you've been infected, that's the blood test for antibodies. Now, people who develop antibodies who have high levels actually can donate blood that can be used then to prepare convalescent plasma, which is a treatment for COVID-19 and also is a source for some of the monoclonal antibody treatments that are being developed. So I saw there was a question in the chat. There actually is a plasma donation center here at Mount Sinai. If you'd like, I can put the information in the chat, how to reach that. If you've had COVID-19 and you've had an antibody test and know you have antibodies and you want to donate blood, then I can give you the link for, how you can
Dr. Rogo has already put the link in there.
Excellent. Okay, good.
Okay, thank you so much for that. I got a question from Maxine S., and it's to all three of you. What follow-up is being done with post-COVID-19 patients? I have a friend battling a severe stroke several months after being released.
Yeah, so there's a whole slew of what we call sequelae to COVID-19, and we're still learning about this. There are lots of case reports and sort of developing data that there are a number of syndromes that this virus leaves lasting dysfunction. It can be, there are some cardiac syndromes. You heard about the inflammatory response that we saw in children. There are some neurologic syndromes. There are some pulmonary complications that can develop. So there are a number of post-COVID syndromes. The issue of stroke is one that's being actively studied right now. There seem to be some changes to the way your blood clots when you have COVID, and there were some early reports recommending that people be anticoagulated when they develop COVID, the same way we give you anticoagulation if you develop a blood clot in your leg or a blood clot in your lung. The same kinds of medicines be given to prevent those sort of clotting, and those blood clots can also cause strokes. So that is actively being investigated. A lot of people think that anticoagulation is a good idea. A lot of people are using it, but there are trials going on right now to actually figure out, does that actually work? So it is real, these post-COVID syndromes, but again, most people recover completely, but there are some exceptions to that.
Thank you, Dr. Easterling.
Yeah, I certainly defer to my colleagues on this. I think the point here is that we got to prevent cases. I think the science is still emerging on this, and I think that has to be our focus, because we're going to continue to learn what the impacts and the effects of this virus is as people unfortunately are infected by COVID-19. And so, you know, even when I hear people talk about herd immunity or COVID parties, I mean, it's really concerning. And I really tried to push back on this narrative. We just do not want people to get infected by COVID at all. And so the most that we can do is really try to prevent transmission. And then when it's not possible, we certainly have to make sure that we have all of our resources available to take care of patients.
Dr. Rogo.
Yeah, I agree with the previous two answers. This is a new entity, and so we are still learning about the effects after someone recovers from COVID. And so right now we're actually still learning the short-term sequelae. And then, you know, a year from now, 2 years from now, 5 years from now, we're gonna learn what the long-term ones are. And they're all things that we don't expect necessarily from having recovered from a virus, right? Yeah, one of the common ones I've been hearing about is hair loss, you know, after recovering from COVID. And a lot of people, even when they say eventually return to baseline, say this is one of the worst things I've experienced, even when it's relatively mild, and that the recovery time, it takes people a while to feel like they're back to themselves. So depending on what your complications are, when you have active COVID, right now seems to dictate your follow-up. So for example, in pediatrics, for those that have the multi-inflammatory syndrome, they're followed by cardiology, rheumatology, and hematology because of the thrombosis issues. So definitely, if no one else, it should be your primary care physician should be seeing you regularly and just doing regular checkups to check on things.
Good, thank you so much. Okay, my question to all three of y'all is, this is the baby booming age, and COVID has been deadly to the elderly. What can a young person like myself trying to take care of an elderly parent do to help them not get COVID-19?
So I'll answer this first. So I and my siblings essentially told my parents not to leave the house. And we did everything for them. So grocery shopping, everything. So that they didn't need to leave the house. My parents are in their mid-60s. Both of them have hypertension. My dad has high cholesterol. So they have risk factors that will put them at risk for severe disease. So that's what we did we also isolated themselves from them. So in terms of visits, stand at the door, wave. I'm not coming in the house, particularly because my sister and I both work in hospitals. We're both high risk. So definitely didn't want to accidentally infect our parents. So I would say, as a young person, if you're taking care of your parents or grandparents or an older relative, to do what you can to keep them comfortable so that they don't have to be out and about. So whether you want to set up grocery delivery or you do the groceries for them, pick up their medications for them as much as possible. If you want to show them the different apps to download so that they can video chat with their doctor. But also, as a young person, I think it's about responsibility. And that's one of the things that's been very disappointing about this pandemic is the lack of social responsibility, right? So even if I'm not necessarily worried about myself, I should be worried about my neighbor, right? So wearing a face mask when you're going to be talking to someone or in a room talking to someone, washing your hands, right? Because if you, as much as you can to do the infection control pieces so that you don't get sick, so that you then expose someone else to get sick.
Thank you very much, Dr. Easterling.
Yeah, so I agree. I think the more that we can do to support our older adults, our parents, while also supporting their agency, because they are our parents, right? And I think we have to sort of find that balance. I think that's going to be super important. Otherwise, they're not going to listen. And why should they, right? But so I think the ways that we could find that balance. I also agree, ensuring that we could maintain connection with our primary cares. I think I have to, continue to say that, and then also get their flu shots. I mean, because we just do not know enough, we have to rely on the things that we do know. And I think those answers just do not change in this moment. And then we just continue to push that message forward. Yeah.
How about you, Dr. Richardson? Thank you, Dr. Eastman.
Yeah, I mean, the only thing I would add to that is that, of course, your parents and older relatives are fortunate to have you to help them. Not all of our elders have that. And so the ability to physically isolate is important in keeping them safe, but we have to make sure they're not socially isolated, because that also has a detrimental effect on health. We have to make sure we figure out ways for them to continue to get exercise and activity if they are staying home to be safe. But if that means they're not walking, and they usually walk, and they're not doing the things that usually keep them active. So again, trying to attend to those things we talked about: good nutrition, exercise, getting enough sleep, while they are being physically isolated so that they are not exposed to people with the virus, is what you have to do. And even if you don't have an elderly relative of your own, there are lots of programs going on so you could help elders who don't have family members, whether it's delivering groceries or making phone calls and wellness checks. And so all of us should be doing something to support our elders during this time of crisis, whether we're related to them by blood or not.
Thank you all for those answers. Dr. Richardson, this is a question from Dr. Miller, and he's asking you, can you speak about lessons learned with emergency treatment, high flow oxygen versus intubation?
Sure. So, and again, I preface all this with, this is a new virus. I can tell you what we know now, or what we think we know now. I'm actually a PI on a study that is looking at the risk to emergency department personnel in caring for COVID patients, to really understand what the risk of doing procedures like intubation actually is. Our assumption was that intubation would be a high-risk procedure. Dr. Rogo spoke earlier about it's mostly droplet spread, but there are some conditions under which those droplets can be aerosolized. This doesn't happen out in the community, but it does happen during certain medical procedures in hospitals. And so then it's really important that the healthcare personnel be very careful about wearing the appropriate protective equipment. And so initially there were a lot of concerns about intubation. There was even concerns about high flow oxygen. Did that actually was the pressure of that high flow oxygen enough to create this aerosolization. So we initially, I think, were very careful, but we learned as we went, and there's a lot of advantages to using high flow oxygen over intubation. If the patient is able to continue to breathe sufficiently, but they're not getting enough oxygen because of the congestion of the lungs from the damage caused by the virus, then often high flow oxygen can get them through without actually intubating them and putting them on a ventilator. There are a lot of known risks and adverse consequences to being put on a ventilator for any reason. So we really don't want to do it unless it can't be avoided. So initially, I think there were perhaps more intubations than there are now, that we are now much more likely to try to keep people adequately oxygenated and not be so quick to intubate, because many of the people who got intubated went on to become what we call chronically critically ill, spending very long time on the ventilators, very hard to wean them, developing lots of side effects and complications. So high flow oxygen is preferred. There's also something called non-invasive ventilation, BiPAP or CPAP. We don't have yet good randomized controlled trials to tell us which of these is preferred in which patients, but we have learned a lot through observation and now compiling large observational data sets to really understand what is the best approach. This is constantly changing. There are new studies coming out every week, so it's evolving. But we've learned a tremendous amount compared to what we do in March. We're taking much better care of these patients. We know a lot more about the disease, but there are still some things we don't know.
Thank you so much. The next question I have for all three of y'all is that unfortunately, I myself have a lot of people that I know that have died from COVID-19. And the question that has been asked by many of them after getting their death certificate, they find on the death certificate that cause of death is blank. They don't understand why it's the cause of death blank in that area when the person died from COVID-19. Can you explain if you can?
I didn't even know you could issue a death certificate where the cause of death was blank. Now, in some states, there's a part of the death certificate that is public, and then there's a part that's confidential. So it might be, depending on where this is, but there is in at least the confidential portion of the death certificate a cause of death. I'm not aware that a death certificate can be issued without a cause of death being indicated. So I'm not sure where this is happening, or if this is some kind of system went down and something didn't get recorded, but that I'm not even aware that that could happen. So I'm surprised to hear this.
Okay, Dr.
I don't know if Dr. Easterling has any insight into how you get a death certificate with no cause of death.
Yeah, I was surprised as well. If they do not have the cause, if it's not listed, I think undetermined or some other language would be used. And certainly what we were looking at as far as death certificate data, both there were absolutely deaths that were attributable to COVID, but then there were also probable causes that were related to COVID as well. And so I know that doesn't get to your question, Rudy, but I just sort of painting this broad picture of how we were looking at deaths during that time, particularly in March and April. But
I told the people
it should never be blank.
Yeah, that's what I thought also. But I told them to get a lawyer, because I didn't understand that either. Okay, to all the panelists, this is coming from Charles Ruffin. Everyone, health leaders in the state of Virginia have brought up the idea of mandatory COVID-19 vaccination to the public when a COVID-19 vaccine has been authorized for use. Also, members of the New York State Bar Association have brought up this idea as well for citizens in the state of New York. what's your opinion since a recent poll has stated 58% of African Americans plan on not taking a COVID-19 vaccine when available?
Yeah, well, I mean, I'll just start and say, that our response has really, we've been really trying to lead with more collaboration and really sort of thinking about the rights of citizens as we've been thinking about this response. And so even as I talked about restriction guidelines, we're not limiting mobility across the city. And so anything where we're talking about mandatory anything, I think there is a concern and could be potentially a human rights issue. So I think we're going to have to think about sort of what are the ways in which we can talk about equitable allocation. We already know that there are just not going to be enough doses immediately, right? And so we're going to have to think about during phase one, who are the individuals that would be prioritized. And so I thought, talked a bit about this allocation framework. And I know, our agencies are really working on this, really in New York State, really New York State Department of Health, as well as New York City Department of Health as well, in collaboration with academic partners. I mean, we have to think about this. One, sort of what that strategy would be, but then I think collectively, how can we support our communities to take the vaccine? And I think, showing the data and having the information is going to be important. But as I mentioned earlier, sort of addressing head on distrust and skepticism has to be a part of it. And I think we can start with flu. And I think we've seen over the years how flu vaccine has certainly fluctuated in our communities, and certainly we have not had high coverages. We're sort of seeing more uptake this year because I think the message is getting there. But we can start here and then sort of talk about what's going to really support individuals thinking, about taking the COVID vaccine. So, one, mandating. I mean, we've been really working with our partners sort of on these citywide policies and how we can really think equitably around this. And we've been bringing in some of our stakeholders, and I think that's going to continue to be important to bring voices to the table.
I agree with Dr. Easterling. I mean, it's really an impractical argument because it will be a long time before we have an adequate supply of vaccine that we could give it to everyone. So the idea of making it mandatory, it's sort of a useless debate to enter. I do want to just go back to one thing that you said when you framed the question, Rudy, that once there is a vaccine that is authorized for use. So what we want is a vaccine that has completed the usual sequence of phase 1, phase 2, and phase 3 clinical trials and has been approved by the FDA through the usual channels. There is a shortcut called an emergency use authorization. That is a mechanism that can be used to, again, fast track something that has not gone through trials, that has not been tested, that is not known to be safe, that hasn't had side effects documented, and which for political reasons is a possibility, okay? So you don't want a vaccine that has been authorized for use under an EUA. You want a fully studied, tested vaccine. So once we have a vaccine that gets to that point, and I agree, we're not going to have one through that route by January. If we have something in January, it will be through an EUA, an emergency use authorization. And that means we don't really know enough about it for us to know that it's safe and it should be widely distributed. But again, depending on what happens politically, that's a possibility. But once we have a fully vetted vaccine, then I agree, it is going to be important that we make sure it is distributed equitably, that we focus on the highest risk populations, but we're not going to have enough of it to make it mandatory. So that it's sort of it's not really an important discussion to have. I have to say though, the path to normalcy that we're all looking for, the path back to the way we were living pre-COVID, involves widespread distribution of a safe and effective vaccine. That is the pathway back to normal. And so we have to do the work to make sure that our communities, once we actually have a safe and effective vaccine, access it. And it's, again, it's about building trust and working those relationships and making sure people understand why this is in their best interest once it actually is in their best interest because we have a safe vaccine.
Okay, thank you. Dr. Rogo?
So as a pediatrician, I do a lot of talking to the parents of my patients around vaccination and counseling around the safety and the side effects, why they're important. And so mandating a vaccine is, I think, has the opposite effect of making people trust that a vaccine is safe and making people be willing to take a vaccine, particularly in this country where people don't like, in general, being told what to do or being forced to do things. So mandating it is not going to be the answer. I think just like Dr. Richardson, Dr. Easterling said, it's about making sure that the vaccine goes through all the phases, that we see the data, know its efficacy, know its side effect profiles, so that we can counsel patients appropriately about what the risks are, if any, will be there in terms of getting the vaccine. And then making sure that the people, when we have the first doses rolling out, that the people who are high at risk have first access to the vaccine.
Thank you so much. There's been hearsay about the vaccine being issued as an experiment treatment in Africa. Now, a lot of people know what happened with the experiment treatment at Tuskegee. What is your thoughts on the treatment being sent out to Africa, and is that true?
So I'm African, and I've worked in Africa, most recently in Rwanda a couple of years ago, and I can say that majority of African governments have protocols in place, just like in the US, in terms of trials for vaccines and for medications. So I can tell you that it's virtually impossible that a vaccine is going to somehow be targeted for trial for use in an illicit manner on Africans. That being said, in order to know that the vaccine works, it needs to be tested in all populations, right? So, because we need to know that not that it just works in the context of the US or context of a white person or Black person, we need to know that it works in all different contexts. So one of the things that is important with clinical trials is inclusion of a diverse population, right? So that you know how it works in different contexts. So one of the things that the National Medical Association has been doing is trying to encourage the participation in clinical trials, right? So that we all participate, so that we can all be confident that the results show that the vaccine is safe and that it works in people that look like us. I'm not much of a conspiracy theorist, so, you know, not that I'm naive and don't think that there are governments that do things and try to assassinate people, and genocides definitely have happened, right? I am well aware of history, but I don't think that it being used in an illicit manner on Africans is really going to be something that's going to happen.
Okay, Dr. Richardson?
I mean, I agree, and I particularly agree about the importance of participating in clinical trials, whether it's for vaccines or medications. That's the only way that we can be sure that it will work for us. But there are vaccine trials going on all over the world, but they are regulated by the governments of whatever country in which they're occurring. And so, again, I I don't think this is a major concern. There's lots of reasons for this distrust. There's a legacy of racism and exploitation within the healthcare system and within the scientific community. So it's easy to understand where these concerns come from, but I think we have to find a path forward where we don't let our distrust keep us from taking advantage of things that actually would benefit us. And so that has to be our path forward.
Okay, thank you. Dr. Rogo.
Dr. Rogo.
He spoke.
Yeah, I mean, just briefly, I think that we have to continue to sort of separate the narrative here. You know, the Tuskegee experiment was deemed ethically unjustified. And I think what we're talking about are clinical trials that are made available to make sure that this vaccine will be safe in all populations. We do not get out of the HIV epidemic without people participating in clinical trials. We don't understand some of the cancer therapies without Black and brown people participating in clinical trials. And so I think we just have to make sure that as we're putting out this message, that we're trying to support people to make sound decisions.
Okay, thank you very much. There's another question from Brian Jones, but I believe you guys answered it, but I'm gonna ask it anyway. It says, is there any merit to the experimental genocidal intentions of this virus by governments? I think you pretty much answered that, but I'm gonna let y'all hit it again.
Well, Brian said yes, it was answered. And I just have to go and just given that we have so many of the illustrious colleagues on this call or at Sinai, that Tuskegee wasn't the first point where we knew these experimentations were happening, right? We had the statue of Marion Sims right there next to Sinai. And so this is a long storied history of medical experimentation. We have books written about it. And so again, there is absolutely credibility to the concerns and skepticism. And I think that's why I think even this space, holding this space to really talk about that skepticism, but also having the space to talk about what is it going to take for us? What is the information? What do we need to make sure that we can get buy-in that folks are going to be willing to take COVID-19, the vaccine? This is going to be so important, as Dr. Richardson talked about, to the recovery, not only to the recovery of our health, but also our economic recovery. We don't get to the reopening plan unless folks are willing to take this vaccine.
Okay. All right. I got a question from Dr. Miller, and he says, Sweden has embraced herd health immunity, and the conversation is starting in the US. Please comment on this approach. And that's for all of you guys.
So herd immunity refers to having majority of people in a place being immune to a disease such that if one person gets it, all the people around them are already immune, right? So that it doesn't spread. In order for that to work, majority of people need to get infected with COVID-19. And we know, even with this period in the spring, for example, I live and work in the Bronx, the South Bronx, where my hospital is, had some of the highest transmission rates in the city. But then when they're doing the antibody testing, it's looking like only about 20% of people have COVID antibodies, right? And that period is something that I never want to go through again. Anyone who works clinically during that time, it was hell. And I don't think we need to go through hell in order to achieve this ideal of herd immunity. I think I don't think it's a good idea, particularly because of the number of people that we're going to lose along the way. Not everyone can survive COVID-19, even among children, even among those that are healthy, right? Not everyone survives it. And for those who do survive it, we're still learning what the short-term and long-term sequelae are of surviving COVID-19. So I'm not a supporter of the herd immunity thing. I don't support people having parties to get COVID. Same reason I don't support chickenpox parties or measles parties, because I think it's irresponsible, personally. So I don't think in the city, for example, in New York City, with all the 8 to 10 million people. So we're saying that we want 9 million people in the city to get COVID-19 so that we achieve herd immunity. I don't see how that's feasible or really good for our overall health.
Okay. Anybody else want to tackle that, Dr. Easterling?
Yeah, well, I'll just say that I totally agree with Dr. Rogo. But unfortunately, I will have to jump at 8 p.m. I'm not sure that we're going past 8 p.m., but I have a meeting that I pushed back.
Okay.
Sorry.
So there's another question here from Clifton Coker, and he wants to know, for those who have tested positive and recovered from COVID, where can they go to give blood for the plasma treatment option for other patients in need? And how long after recovery can this blood be valuable?
So you can give blood. That it's actually in the chat now. The link where you can get information about how to go donate plasma. There's a plasma donation at Mount Sinai. There's also one at the New York Blood Center. There are a number of them around the city. It's not so much how long after you had COVID as how high your antibody titers are. And again, we see a lot of variability with this from individual to individual. Some people never have the level of titers that is required for you to be eligible to donate plasma, and other people have had it sustained for months and have donated multiple times. So it's very individual. If you're interested, you should go and be tested. You need a quantitative antibody test to actually measure the level of antibodies in your blood. Most of the tests that people are getting are just positive or negative. So you don't know, but if you have that, you should go get a quantitative test and donate the plasma if you qualify. So there's only one way to find out. You have to get a blood test to find out if your titers are high enough to donate.
Okay, thank you, Dr. Easterling. I know you have to go, so I'll let you answer that question. I'd like to thank you so much for participating and being on our panel. We hope to see more of you again. All right, so you can answer this last question and we'll say adios for now.
So remind me of the question.
Okay. If you have recovered from COVID and want to donate your plasma, you can find info. Hold on. I'm trying to read out the chat here where that question was. Okay. For those who have tested positive and recovered from COVID, where can they go to give blood for the plasma treatment option for other patients in need? And how long after recovery can this blood be valuable?
Okay. Yeah, I actually do not have much more to add than Dr. Richardson has already answered. But I'll just sort of piggyback on the previous question about herd immunity here, just because I think, as we've already mentioned, that the science is still emerging, and so there's so much more that we need to know, and to the point that we still don't yet not even clear about the potential of reinfection. But I think we are started seeing some reports of reinfection, and knowing that that's a possibility. You know, to the points that Dr. Rogo had already mentioned about different strains and even learning. I mean, herd immunity is just not something that we can even have a conversation about, and shouldn't really be putting that out there, and really, I think, pushing back on that narrative. But you know, I think, you know, just really using the science and the data to really understand what we're dealing with here, keeping folks safe, I think is really, really key here. So I'll just leave on that note, and really thankful to 100 Black Men for having me and panelists, and look forward to joining you all in the future.
Be safe, doctor.
Thank you.
Thank you, Dr. Easterling. I think Rudy, and it may be that the other panelists need to be winding down soon as well. So maybe, I mean, there may not be, there may just be another one or two questions. And
Yes, it's one question by Dr. Miller. It's a very simple question, but it could be a difficult answer. True, true or false? Hand sanitizer is just as effective as hand washing.
True. As long as your hands aren't soiled. Right?
Yeah, I was going to say, yeah.
If your hands are visibly dirty, you should wash them with soap and water.
Yeah, effective for what is the question. Exactly what was just said. If I have mud on my hands and I pour hand sanitizer on it, to me, my hands are still dirty. So I like hand washing. I preferentially hand wash when I'm working over just using hand sanitizer. But if you have washed your hands and you haven't really touched anything that's dirty, but now I'm just going to the next patient and I want to reinforce that hand, hygiene, then I think the sanitizer is a good question. But I would encourage you to wash your hands whenever there is sink and soap and water available. When there isn't, then the hand sanitizer is a good alternative.
Okay, Dr. Rogo, what do you say?
She answered first, actually.
She answered already, okay. All right, so I think that's got all the questions in the chat. I'd like to mention, is Dr. Lindsay still on? Dr. Lindsay, are you on?
Yes, I am. I'm right here.
I wanted to mention that you are one of the co-chairs, and we just had a phenomenal event right now. And
we sure did. We sure did. I want to thank Dr. Rogo and Dr. Richardson. Dr. Easterling, I know he had to drop off, but what an incredible conversation, enlightening. I thought about my 80-year-old mother in DC a lot, and the things that my siblings and I need to be doing differently to ensure her safety and well-being. Certainly she does not go about in terms of being exposed or being at risk in other ways. And so that was helpful, because what you laid out tonight was just so stimulating and important. I wish the whole world could hear these three Black doctors lay it out like that for our community. One last thing I will say too, I was really intrigued by the conversation related to the vaccination. I was playing golf this summer with an emergency room doctor at Howard University, and he was telling me about all the things that he's been seeing in the emergency room. And so I asked him about the vaccination, and his response really shocked me. He said, F no, I'm not taking that. And he said, I'm a doctor. And I was just really surprised by that. But I think it was Dr. Richardson who said it, like, we don't get to a recovery process and plan until we all are really clear about this vaccination thing and how important it is to the process. And so that's my perspective on it. And I appreciate all that you contributed tonight. So thank you so much.
Thank you, Dr. Lindsay. Dr. Butts, your perspective, please.
I think this was great. This is, we need more of this. That's my opinion. And why not? I don't think it can be any better than from folk who have walked our paths, but who also can appreciate what's happening on the inside, if I can put it that way. And so my hope is that I look to Courtney and Anthony that there is a way to retrieve this, and so that we can push it out, assuming that I would assume that the panelists are comfortable with that, at least hold on to it so that it's available to others who couldn't be with us tonight. And I just want to thank, again, the panelists, and thank you Rudy, for a great job. We knew it would be great, but this was just wonderful. And thank my brothers and sisters for coming out with us tonight.
And in closing, I have to introduce our newly elected president to close it out, Aldrin Ennis. Aldrin, are you still on?
I am still on.
Okay, all right.
Rudy, thank you very much for moderating the conversation. I thought this evening was exceptional. The 3 doctors that we had on board, I actually learned a whole lot, and in particular with the masks. Unfortunately, I got the lowest level mask at this point, but clearly I need to upgrade. So thank you all for the knowledge. I'm glad that we did record it so that we can, play it again, as Dr. Butts has mentioned, for those who did not have the chance to join us this evening. And once again, I definitely got to give a shout out to the Health and Wellness Committee for the great work that they've been doing, and keeping us aware as far as what is going on, in particular with this pandemic that we've been heavily impacted by. It all comes through knowledge, right? If you have knowledge, that's the first step. So thank you for sharing your expertise with us. And it's always great to see Black people. So I'm truly happy to see all you guys. And once again, Rudy, thanks a lot for the work that you've been doing.
Thank you for having me. Thanks everybody, panelists, everybody that participated. Be safe, stay protected, and God bless.
Hey, thank you. It was my pleasure. Bye-bye.
Thank you all.
Thank you.
Good night.
Thanks. Good night. Great job.